We're going to get started. Welcome, everyone. I wanted to welcome you all to the webinar this evening. Oh, this is what happens when you live in an Amber Alert area. I wanted to welcome you all. For those of you who don't know me, my name is Dr. Lauren Levine. We have a great turnout tonight. Well over 600 people are registered. We always get great turnout when Dr. Kosinski is presenting. As always, I hope everyone is staying safe and healthy. Hope you all had a good New Year. Commend you, of course, for being here this evening and continuing dental education. I'm going to speak for a couple of minutes, get a little housekeeping out of the way. I want to make sure that Tim can speak for as long as he needs. We always leave time at the end for questions. Most of you have been on the webinars in the past, so you kind of know the format, that our presenter will talk for 45 to 60 minutes, give or take. We have a sponsor tonight, so we'll turn over to them for a few minutes afterwards, and then we leave time for questions. When we have 600 people on, we can't do verbal questions, obviously. All of you on your screen should have a GoToWebinar control panel, and you can type in your questions as you think about them. As I said, we don't typically get to the questions until the end. Depending on how many questions we have, sometimes I may need to combine a few of them together, but we'll do our best to get to every one of those as well. In the next few days, look for a few things. First off, I am recording this webinar. The webinar link to that recording should typically go out within a couple of days, sometimes a little bit sooner than that. So if for some reason you can't make it to the end, don't worry about it. You will be able to watch it in its entirety. During the webinar, Dr. Kosinski is going to talk about some of the products and systems that he uses, which are exclusive to GoldenDent. I've been working with Kurt and GoldenDent for, I think, close to 10 years now. They're the ones that sponsor these webinars. They're the ones that bring in the speakers. They develop the topics. And it's just a thrill to work with them. They're also the ones that handle the CE. And I always get questions after the webinar, and I'll probably mention it at least a couple of times. The way that the CE works is an automated process. There's nothing that you physically need to do. No registration, no quiz or test or anything like that. When the webinar is over, I send the report to GoldenDent. It'll show when you logged in, when you logged out. If you are listening to this on the phone and you just dialed in, you are not logged in. There's a link that you all would have been sent unique to you. You have to actually click on that link to be registered. If you can see the screen, then you're logged in. But that will go out to everyone. You have to be here for the bulk of the webinar. I think it's like 40 or 45 out of the 60 minutes. But they will handle that. That takes a little bit longer, oftentimes up to a week or so. Usually they're pretty good about getting it out in 2 or 3 days. But if you don't have it, say, by next week, by all means, please feel free to reach out to me. I will follow up with them and make sure you get your CE. With that out of the way, as I said, whenever we get Dr. Kosinski in, we always get a great turnout. If you are in dentistry, then you probably know who he is. He is an affiliated adjunct clinical professor at the University of Detroit Mercy School of Dentistry. He's on the editorial review board of Reality, which is the information source for aesthetic dentistry. He's the past editor of the Michigan Academy of General Dentistry. He is currently the editor of the AGD Journals, General Dentistry and AGD Impact. He was named editor of Implants Today. A couple of years ago, he was presented with the AAADEJ's Distinguished Editor Award. He's past president of the Michigan Academy of General Dentistry. He is a wet-fingered dentist like most of us. He got his DDS from University of Detroit Mercy Dental School. He got a mastership in biochemistry from Wayne State University School of Medicine. He's a diplomat of the American Board of Oral Implantology and Implant Dentistry, the ICOI, and the American Society of Osseointegration. He's a fellow of the American Academy of Implant Dentistry and also got his mastership in the Academy of General Dentistry. He has received numerous honors, including fellowship in the American and International College of Dentists and the Academy of Dentistry International. In 2017, he received the Academy of Dentistry International's Humanitarian Award, which was a recognition of significant contributions to the enhancement of the quality of life in the human condition. He's a member of OKU and the Pierre Fauchard Academy. He was the University of Detroit Mercy School of Dentistry Alumni Association's Alumnus of the Year. And in 2009, 2014, and 2020, he received the Academy of General Dentistry's Lifelong Learning and Service Recognition. If you think you know a lot about implants, he knows more because he's placed about 19,000 dental implants. He's published over 250 articles on surgical and prosthetic phases of implant dentistry, over 100 dental editorials. He was a contributor to a few textbooks, including Principles and Practices of Implant Dentistry and Dental Implantation and Technology. Tim, always a pleasure to have you here. Really looking forward to the presentation, and take it away.
Thanks, Lauren. Can you hear me okay? We're
I
good?
can hear you fine.
Perfect.
Yep.
You always make me giggle when you introduce me. It's a little humbling. So thank you for the introduction. So, and I thank the team at GoldenDent for bringing me on again. It's always a pleasure to kind of share the information that we're able to do in our practice every day. Lauren, as you mentioned, we do a lot of implants in the practice, a lot of restorative work, and but as important as placing the little spark plug in the jaw is building the hard tissue to an appropriate level so that we can successfully place implants. I know many of you listening are maybe new to implant dentistry. Some may have a lot of experience. But the most important thing that we have to realize that I want to leave you with is that we have to build the foundation to have the house in place. Lauren, you mentioned windstorms and fires where you are. So it's very, very important. Those of us, we have several concerns in the oral cavity as far as implants go. The posterior mandible and the posterior maxilla. And we will focus on those two areas as well as the aesthetic zone to some degree tonight. So enough being said, our topic today is, efficient, predictable, and cost-effective grafting to implement in your practice this year. And I think all those terms, all those adjectives are very, very important. We want predictability, but we also have to be proficient and efficient in what we're doing. Lauren, as you mentioned, I'm a GP in Detroit area, and I do surgery just about every day. We're doing anywhere between 80 and 100 implants per month in the practice, and I am on the road a lot. So building the foundation is very, very important, and hopefully we're going to be able to plant a seed in your practice. The team at GoldenDent has some excellent products that, again, are very, very cost effective. So it allows us to provide a high quality service to our patients at a reasonable fee, and that's what makes you successful. Lauren, you mentioned that, I practice outside of Detroit. And I mentioned the website there, drkosinski.com. That is an education website, and I think it's a very good resource. We have probably 200 YouTube videos there. So some of the things that we're showing here today at my publications are there. It might be another good resource for you if you wanted to get more information. And that's a beautiful view of northern Michigan. That's Lake Michigan, where we have a place, and it's just my therapy place. So what are we going to do tonight in the next hour that we have together? We'll talk about atraumatic extractions a little bit, not a lot, but extraction techniques are very important. Maintaining the hard tissue makes our job a lot easier. If we can maintain our walls of our socket sites, it makes the grafting and or immediate implant placement that much easier. We coined the term atraumatic, Kurt, probably, wow, maybe 10, 15 years ago. And originally we were criticized for that term. How can extractions be atraumatic? When I talk about atraumatic, minimally traumatic, we're talking about giving the patient a positive experience. And we'll show you the techniques that we use to minimize the pressure that goes along with extractions. Atraumatic to the bone or minimally traumatic to the bone, maintaining bone is, or the hard tissue is very, very important to me. Bone is gold. And maintaining that bone for predictability and a better prognosis is important. And then as important, atraumatically or minimally traumatic to us as practitioners, taking teeth out is really hard. We sweat under our armpits, our collars get yellow stained. We leave a lot of root tips. in the jaw because it's very frustrating. So we'll spend a little bit of time in the extraction technique that I literally use every single day, and I wouldn't practice without it. We'll talk about a couple different bone grafting materials that are available through GoldenDent, and they're cost effective. And I think Kurt at the end will have some specials. It's a material that I use in my practice. And again, it's cost effective, and it makes my ability to provide the service to our patients, especially in the economy that we've had over the last couple of years, very, very, very important. Grafting techniques, another material that we're going to use is very low cost, and we can grow bone. I'm going to say something very bold. We can grow bone, a socket and a facial plate 100% of the time. And that's a bold statement for this dentist out of Detroit to make, but I feel very comfortable if we follow the protocol and the recipe for success that I'm going to provide today. You can promote bone healing very, very efficiently. And again, it's very, very important that we graft our sites predictably. Many of you are here because you understand you're taking teeth out, you understand that it's important to graft, but every once in a while you get a bad result where the bone didn't turn over. So we're going to show you the techniques that we use to kind of predictably grow bone without having to worry about it. And then suturing over our surgical sites is important. We won't spend a lot of time with that, but suturing is as important as any other technique that we use, that we do in our practice. I'm going to do this quickly. When we lose bone, bone shrinks, right? In the mandible, bone shrinks down and in the posterior maxilla, the bone shrinks up and in. We can lose horizontal bone in the aesthetic zone, and it makes our implant procedures, which is the most financial rewarding thing we can do in dentistry. It is so very popular, so different than when I started placing implants back in 1985. We are going to lose bone in the posterior maxilla. Not only do we lose bone up and in, but our sinuses have a tendency to collapse, and which makes placing an implant prohibitive without a much more invasive surgical procedure. So we lose bone, height, width, and as teeth are lost, we lose facial form and aesthetics in the face. If we learn to graft at the time of extraction, and these next two slides are very, very important if you want to take a snapshot of them, because this is communicating with your patient. You have to explain why, when we take a tooth out, it's important that we put something in there to minimize bone loss. If we take a tooth out, bone is going to shrink down and in the lower jaw, up and in the upper jaw, and the sinus is going to collapse. So if we graft with one of the materials that I'll demonstrate today, we're going to minimize bone loss. It's going to help support soft tissue, help minimize periodontal pathology, and we can routinely provide an adequate site for a dental implant placement in a very short 3 to 4 months. And we can objectively determine when we get bone turnover. If you don't graft, and many of our patients will say, "Oh, doc, I don't want to spend the money on that. I don't want to pay for that." And our dental insurance oftentimes doesn't pay for grafting procedures. Epithelium will grow into the socket. We will get loss of height and width of the ridge. And the literature says we will get 30 to 60% bone loss in a 3-year period, which means if the patient doesn't elect to have grafting and down the road we get bone loss, they may have to go through a much more invasive, expensive surgical procedure to prepare a site for implants in certain areas. As I mentioned, some of us, have grafting failures, if the wound opens ahead of time. So suturing is very important. If we're using an allograft material, human bone, we must protect that graft from invagination of epithelium. So we must use a membrane that must remain intact for at least 6 weeks. We don't necessarily need primary closure with our modern membrane materials, but it's important that that membrane remain intact. Epithelium grows 10 times faster than bone. Physiologically, the way a socket heals, it heals from the apex towards the crest. Epithelium grows from the crest towards the apex. Epithelium will always beat bone. So if we protect an allograft from invagination of epithelium, we will have a much higher chance of bone integration to a site. If we leave a site infected, if we have an infected tooth, it's important that we curette, eliminate the granulation. I may use a diode laser to sterilize the site. We don't want to leave an infected site in place. I will never immediately place an implant in an infected site, a site that has an abscess. However, I will extract a tooth, an abscess tooth, and curette or use my laser and place a graft material. And I guess the analogy I would use is like if you had a hangnail. If anybody here's had a hangnail, it's very painful, miserable, right? You go, you soak your foot, you clip the nail. 5 minutes later, your body forgets that you even had any discomfort. The body is an amazing thing. If we eliminate the source of infection, the site will heal. The resorbable membranes that we use from GoldenDent are resorbed in 3 to 4 months. I need a membrane that lasts 6 weeks. It's purified intact collagen from porcine peritoneum, and it's very easy to manipulate and control. That membrane must be positioned passively at least 2 millimeters beyond any defect. At least 2 millimeters beyond any defect, and that's critical. Okay, many of us understand, you know, we graft and we place the membrane, but we like to tuck, especially as general dentists. We like to tuck, and a membrane will tear, it'll bend. We get frustrated, we suture over the top, suture removal, or the patient plays with it, and the membrane is taken out in a short amount of time. In those situations, the integration of the graft becomes unpredictable. So we want predictability when we're using an allograft and a membrane. Our allograft material is cortical cancellous. It's osteoconductive. It allows for structural integrity. And in a very short 3 to 4 month period of time, we will get integration of bone starting from the apex towards the crest that will allow us to create a site appropriate for dental implant placement. We wet this allograft material, this particulate, with sterile water, sterile saline, never anesthetic. Anesthetic is pH of 2, and if you've ever mixed your allograft with anesthetic, again, the results may be unpredictable. So sterile water, sterile saline. The GoldenDent particulate is the highest quality at a very reasonable cost. So for those of you who are investing in this product, I would talk to Kurt and the team at GoldenDent on the materials that are available for you to use. Another graft material that we've used for years is EpiGuide, and it's a synthetic material. It's bioresorbable. It's 3 layers of polylactic acid, and it maintains its integrity for 20 weeks. Remember, if I'm using allograft, I need a membrane placed at least 2 millimeters beyond any defect, and it must remain intact passively for at least 6 weeks. If you're able to do that, you will grow bone predictably, and you don't need primary closure. The other material that we use a lot is called the Osteogen plug. It's a calcium apatite particulate in a bovine Achilles tendon matrix. It is truly a graft material. This is not a collagen plug. It is truly a graft material with about 30 years of research behind it. If I have a socket with all walls intact, this is my go-to material. It's very inexpensive, very easy to use, very easy to place, okay? We place it to the crest of the ridge or slightly above the crest, and I can thread an implant directly into it. When we take a tooth out, we create a socket that's basically shaped like an egg. Our implants are round. So we fill that gap with a caulking material. This Osteogen plug is an excellent material. If I have a facial wall missing, my go-to will be an allograft and a resorbable membrane. Easy and effective to use, very, very nice material. It is truly a graft. It's also a membrane. You do not need to use a membrane with this material. And the bovine Achilles tendon matrix prevents invagination of epithelium into the socket. So nature has two options. It can try to dig through the material, or it could grow over the top. And nature will always follow the path of least resistance. So we can use this material that's very cost effective, very inexpensive, and we don't need a membrane with it, and we can grow bone. So if we take a tooth out, this is just an idea of this is what the osteogen plug looks like. There's various sizes that you can talk to Kurt about at the end as you're ordering. It's very inexpensive. We remove the tooth as atraumatically as possible. We curette the socket. Curette, 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 curette. Remove the granulation. Red blood is good. Purple blood is bad. And we can simply place this material. The blood will absorb right into it. And I will place it to the crest or slightly above the crest. I will then simply take a couple interrupted sutures and suture over the top of it. Now we tell the patient no heavy spitting, no straws, no crunchy foods like nacho chips, potato chips, popcorn, things like that. Personally, I like to see my patients, if I do surgery, I like to see my patients in a week to 10 days. I like to remove these sutures. These are Vicryl or polyglycolic acid sutures that are resorbable in about 21 days, but I like to remove the sutures. I like to see how they're healing. Epithelium grows a 0.5 millimeter to 1 millimeter a day. Depending on the size of the socket is going to dictate how quickly the epithelium is going to grow over the top of this material. And I like to see it. Everybody heals a little bit differently. Patients with medical concerns or elderly patients may take a little bit longer to heal. But when the patients come in, we'll remove the sutures and I'll tell them, boy, you're a great healer, or you're 70% healed. Be a little bit careful for the next week. I want predictability. You want predictability in your practices. So here it is. Immediately following the graft, you can see some radiolucency there, right? You know, it's the material, there's some radiopacity, but some radiolucency. But in 4 months, I can take a digital radiograph, and I think you can all see a change of some sort. Now, remember, if we're going to place an implant, our initial stability with any implant system, the one from GoldenDent or any implant system, is in the apical 2 millimeters of the socket. So we have better bone turnover in the apical, maybe half in this radiograph. And we're going to do our osteotomy and place our implant and get great initial stability. And I'm going to allow that implant to heal for another 3 to 4 months. That bone turnover is going to continue over that period of time. And this is routine, doctors. Here we have a site. We're going to do a tissue punch, meaning we're just simply removing the soft tissue over the socket site. I do a lot of histology in my practice, so I did a core sample of that. Remember, that was a pretty big socket, lots of graft. We waited 4 months. I did a core sample, and let me back up here, sorry. The histologic evaluation, when you see the magenta there, magenta is bone. We're getting bone turnover. The purplish or violet color material there is the graft material that has not turned over. And you can see we have more bone turnover in the apical portion than we do in the coronal portion. I'm able to place an implant in the socket. Remember, my initial stability is the apical 2 millimeters. And I was able to torque this implant, for those of you who do implants, to 45 Newton centimeters in a grafted site, extracted and grafted site. That's tremendous initial stability of my implant. So I expect a good result. After 4 months of healing, here we took an analog impression. The laboratory fabricated a nice screw-retained zirconia crown. This is certainly within your wheelhouse, and doctors who aren't involved that are listening today, it's imperative that you get involved in this procedure. There's a lot of proper training courses. GoldenDent has some wonderful training programs with both extractions, grafting, and implant placement that you should be involved with to get the same results that we get. This is really predictable dentistry. Yes, I know somebody's going to ask, last time we did this, people were asking about PRF, PRP, platelet-rich fibrin, platelet-rich platelets. And what that simply means, it's autologous platelets and leukocytes are present in a matrix form. We will draw blood, we will spin it, and we will actually get a bioactive material. The end result of the graft is not any better, whether you use PRF, PRP. It just occurs faster. So rather than waiting 4 months for integration, we may get something done in 2.5 or 3 months. The technique means you're drawing blood. You can take a phlebotomy class at most community colleges and to show you how to do this, or you can train your staff to do it depending on where your state is. And I'll run through this video really quick. Here we're just taking a tourniquet, finding a vein, very small butterfly needle, and we will harvest the red blood cells in particular tubes. I don't do this routinely in all my cases, but in the bigger cases, or depending on their medical condition, I will simply do this. It's just a matter, really just a matter of minutes. And certainly within your wheelhouse also. We will spin the material. So I will be finishing my surgery as this is spinning. We have a little box. We take the fibrin clot and we will compress it. The PRP is, there's not very much there, but again, it helps stimulate bone growth. We can cut up that fibrin clot. We can use it as a membrane. We can make sticky bone. And again, the bone turnover is just a little bit faster, not necessarily better. Here we took a tooth out. We curette, 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 curette. Here I'm taking my allograft material from GoldenDent, plugging it in here. I took my PRF, my platelet-rich fibrin membrane, and I will suture over the top of it and allow for integration to occur. So rather than 4 months or 3 months, it may be 2.5 months for me to be able to successfully place an implant. I don't need primary closure, and we'll allow that to heal. I know last time, Lauren, we were asked that, and so I thought it was important. If I have all walls intact, we'll call that a 5-wall defect if you consider the floor to be a wall. I will use routinely the osteogen material. It's inexpensive, easy to use. I can do immediate implant placements. I can do socket grafting. I don't need primary closure. I will suture over the top. If my facial wall is missing, due to physiologic disease, due to fracturing of the facial wall, if that facial defect is 5 millimeters or less, I will still use osteogen material. If it's greater than 5 millimeters, I will make it a reflection. I will place the membrane that we talked about earlier. I will make sure that I position it at least 2 millimeters beyond the defect, which means you have to know how to reflect. You have to feel comfortable reflecting. This is not a time to be delicate. This is a time to see the defect. If you can see the defect, you can fix it. So that membrane is placed at least 2 millimeters beyond the defect. I'll take my allograft, wetted in sterile water, sterile saline, and I can grow a facial wall. I can grow a facial wall with an immediate implant in place also. Let's get to some clinical demonstrations. So we have a tooth that's deemed non-restorable, and we're simply going to remove it. Now, again, this is another great tool from GoldenDent. It is a crown remover that works very well. And rather than sectioning the whole crown from facial to occlusal to lingual here, I will simply make a elliptical window. If it's a zirconia crown or a Bruxer crown, I will use a round diamond to make a little window. To the central groove area, I will simply take this instrument that has it's a high quality stainless steel with a ball on it, and I will simply rotate my wrist, and that crown will pop off in a matter of seconds. So very, very time efficient removal. Now, this is not a tooth that we're going to keep. So I have a mandibular molar. I'm going to take a 557 long surgical burr, and I'm going to section it through the furcation. Taking a mandibular molar with divergent roots can be challenging. It's hard. And I do see a lot of broken root tips left in. So if I section it, I'm able to remove this tooth as two individual bicuspid single rooted teeth. It makes it very easy. I'm making sure that I section through the furcation. So I'm getting a little bit of movement. Take a radiograph. You can see the design of that root would be very, very challenging to take out in one piece. And this is another great instrument. I would not practice without the physics forceps. I know this is not an extraction program, Kurt, but it's a set of 4 instruments, upper right, upper anterior, upper left, and lower universal. It's not an expensive set of instruments. This is my go-to. If I'm going to take out a lower molar, my team will bring me 1 instrument. The little green cover is a little bumper. They're disposable, okay, not expensive, and it just acts as a little bit of cushion on the soft tissue. There's 2 components of this system. The beak is the working end of the instrument. It's a shovel-shaped edge that will engage the lingual or palatal aspect of the root. You have to have a purchase point, 1 to 3 millimeters subgingival. The bumper is not the working end of the instrument. It will be placed as far down into the vestibule or as high up into the vestibule in the upper jaw as possible. It is not holding the facial plate. It is simply acting as a pivot point or a center of rotation that allows the tooth to luxate up and out of the socket following that very specific arc of rotation that was created by Dr. Golden. We are not squeezing the instrument. We are not squeezing the instrument. Rather, I'm simply rotating my wrist towards the shoulder with constant pressure. In a matter of seconds, this tooth will pop up and out. The instrument is not intended to remove the tooth in total. Rather, it's intended to luxate the tooth up and out. How does that work? We're creating tension here on the lingual aspect of the tooth, which is resulting in a physiologic reaction. We are getting an enzyme released by the body, which is breaking down the periodontal ligament. What's holding this root in place? The periodontal ligament. If we melt away the periodontal ligament, that tooth will dislodge in a very short amount of time. Excuse me. And you can see I'm just using thumb pressure on the upper part of the instrument. I am not squeezing the instrument at all. This is a great instrument for those of you who may have manual dexterity or limited strength in your hands. We're not squeezing. You can see I just have it laying in my hands and I'm simply rotating, creating tension on the lingual aspect of this root. Tooth will pop. We're going to evaluate the site. I always take a radiograph after I take a tooth out. I want to make sure that it's out in total. And then I've taken my Osteogen plug material. I cut it in half. You can cut it. And I'm simply filling each socket individually. Now, oftentimes in these courses, you'll ask, what kind of sutures do I use? We all have our favorites. I use PGA, polyglycolic acid synthetic material, which resorbs in 28 days, 21 to 28 days, and it resorbs to water. So I don't get a lot of inflammation. And I get it from GoldenDent, very, very reasonable in cost. I never use silk anymore. Silk absorbs plaque, and it's just irritating. Plain gut, chromic gut, many of us use that. It's inexpensive. Again, we all have our favorites and how we manipulate it. we can use, I have 2 needles in my office. I have a 3/8 circle and a 1/2 circle. And the thread size goes from 3 to 6. I will purchase a 3/0 and a 4/0. So I have 4 sutures in my practice of PGA. 3/0, 4/0, 3/8 circle, 1/2 circle, all of PGA material. So we grafted the site with our osteogen. I do not need a membrane. Placing it to the crest or slightly above the crest. You can see the radiolucency to some degree immediately after placement. I place my interrupted sutures. I do not need primary closure. Epithelium, again, will grow 1/2 millimeter to 1 millimeter a day. I like to see my patients in a week to 10 days if possible. If they're leaving for Florida or going on vacation, I tell them the sutures will resorb on their own. But I like to see my surgical patients, especially elderly patients. I want to see how well they're healing. If we look at a CBCT after a very, very short 3 months, you can see the socket is generating bone, more so in the apical portion than in the coronal half. But my initial stability with any implant system is going to be in the apical 2 millimeters. So 3 months post-op, I now have a site, and I'll run through this kind of quickly. We now have a site that all of you will have bone growth where you are going to feel very comfortable placing an implant. Now, I'm going to infiltrate. I never block implants. It's only soft tissue that we need to anesthetize. Bone has no pain receptors in it. We know that nerves run through bone. We're worried about the mandibular canal and the mandibular nerve. But you can see I'm just walking up that ridge, blanching that soft tissue. Just blanch the soft tissue. I'm looking at the mucogingival line. Here I've taken an Orban knife, O-R-B-A-N knife. It's a specially designed surgical blade, stainless steel surgical blade. And I'm going to reflect that tissue. And I like to say it's an envelope reflection. I do not make vertical incisions in my surgery. I try to stay into mucosal tissue. If you do this procedure, you are not going to have a lot of post-operative discomfort. If you make vertical incisions into mucosal tissue, you will get prostaglandin and histamine release, and the patients are going to swell, bruise, and be uncomfortable. So make that envelope reflection, and you can see I didn't even reflect the lingual tissue here. I can see the bone, and you can see my drill system is, I'm working hard. Normally I would like you to use 2 hands, but for video demonstration, we created bone in a huge socket in 3 months. Predictable bone. You can see the high quality material, and I'm working that a little bit. And this is what I expect in all my grafting cases, With any osteotomy, you know, I don't want to go through too much of the implant procedure. We start with a small diameter drill to a bigger one, to a bigger one, to a wider one, and we can harvest that autogenous bone. And here, our last drill, we're going to thread our implant into the socket, and then we're going to torque it to the crest. I'm looking at the time that it took me to do this, and it's about 4 minutes. If we get to 25 Newton centimeters of torque, I can place what we call a healing abutment, which eliminates the need for anesthesia on uncovering. If I get to 35 Newton centimeters of torque, the literature says we can load the tooth. If I get less than 25 Newton centimeters of torque, I will place a cover screw and bury it, and we would have to uncover it later. So look at this tissue after 3 months of healing. Here we have a scanning pin, 3 months. And we fabricated, either you mill it in your office today or send it out to the dental laboratory. Here we did a screw retained zirconia crown. We covered over with a little composite, and you are able to restore your patients to form and function. This is the most efficient way to do dentistry today. Obviously, we always communicate with the patient and give them options. There's nothing wrong with doing a conventional bridge here. Leaving the space open isn't the end of the world. But our patients today are very responsive to dental implants. Another tooth that's deemed non-restorable, huge infection, right? I'm going to go a little bit quicker here, Lauren. And we're going to remove this tooth as atraumatically as possible. Now there's a huge bone loss in that site, so I'm going to use a cow horn, placing tension on that periodontal ligament, remove the tooth, and curette. Curette, 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 and look at the snot that is in that site. You must remove that. We have a huge cereal bowl there, don't we, doctors? A huge cereal bowl. We're going to make my envelope reflection, not incising into mucosal tissue, eliminating release of prostaglandin and histamine. We're evaluating that site, and here again is the osteogen plug material. Placing it where? To the crest, slightly above the crest. Couple interrupted sutures. 3 months post-op. Remember how large that defect was. Our CBCT analysis allows us to evaluate that site, draw in the vital anatomy, the lingual concavity, the mandibular canal. We can virtually place our implants today. We can virtually design our final restoration prior to any surgical intervention. 3 months. Doctors, I want to prove this to you. We're taking my Orban knife. I'm reflecting the tissue. And what do you see, doctors? Bone. It may not be completely mature. It takes about a year for bone to mature completely. But I'm going to place an implant, getting my initial stability in the apical 2 millimeters, and allow that implant to continue to integrate and heal, and the surrounding bone will continue to integrate and heal over a period of time. And this is what I mean by an envelope reflection. So no vertical incisions. Again, we did a core sample in that huge, huge cereal bowl defect. And again, magenta is bone. The purplish violet color is the graft material that is still not turned over. We're going to go through the same process of our osteotomy, small drill, wider drill, small drill, wider drill to our final diameter burr. We'd like to place an implant that is half the diameter of the tooth we're trying to replace. Our limiting factor is oftentimes facial lingual or facial palatal. So grafting is a very, very important part of the procedure. We place our implant and we torqued it in that grafted site after 3 months, again to 45 Newton centimeters. That's incredible torque in that area. Because we were able to achieve a certain amount of torque, I can put a healing abutment, torque that to 25 Newton centimeters. We have a band of attached gingiva on the facial aspect of my implant. And 3 months post-op. This is what you expect, I expect to get in my practice. If you take your time, understand the principles, understand the rules, you will achieve the same results that I get every day in my practice. It's not magic, it's technique, it's recipe. And we're able to restore our patients to form and function quite remarkably. If we go to the, I'm going to do this kind of quickly. Actually, this is a friend of mine, and she had internal resorption. She came in today for number 9. She has the same internal resorption on number 9 now, so we're going to be placing an implant there. She's leaving for vacation. So we're going to remove the tooth with our physics forceps. You can see I'm not squeezing, I'm just simply putting tension on one handle, not squeezing. The patient really don't experience that tension that you normally get when you're doing an extraction. And in a matter of seconds, that tooth will pop. I will then take a tooth delivery and remove the tooth, maintaining the facial plate, curetting the site. And here's a drill system from GoldenDent. It's a wonderful drill system, very, very cost effective. And then again, I don't want to go through too much implant stuff. You know, we're going to do our osteotomy. Here I took my osteogen material, placed it into that socket after the osteotomy, and I can simply thread the implant directly into that site. So the material acts like caulking. We're going to place that implant about 1 millimeter subcrestal. We'll put a healing abutment, and we made a little flipper for this patient, and we'll let her go. All right, let's get into some more complicated. What about this site where we have a split root? I think we all agree that this is not a tooth that we're going to be able to save. Don't we all love posts? Since COVID, I think I've done more implants on root canal treated teeth with posts that have fractured than anything else. It seems it's a weekly thing, and I think the stresses created in life today are making patients put a lot of damage to their teeth. So we remove the tooth, and you can see that huge defect. You can actually see the Schneiderian membrane of the sinus. It's not perforated, but that little grayish there on the distal is actually the Schneiderian membrane. So how am I going to repair this? I'm taking my osteogen plug. I'm going to make a little sandwich. And I'm going to use this material because it has some substance, some feel to it. And I'm actually going to push that Schneiderian membrane apically. I can move that Schneiderian membrane up to 6 millimeters without perforating it. And so I love the osteogen material, which is truly a graft. Okay, it's not a collagen plug. And then I'm going to sandwich my allograft material from GoldenDent. Now, what did I say earlier? If you're using allograft, we must protect it from invagination of epithelium. So I will use a collagen membrane that must be placed passively at least 2 millimeters beyond the defect and must remain intact for at least 6 weeks. I'm simply folding it onto the lingual, and I'm going to suture. We'll go through this a little bit quicker. And immediately following the graft, you can see allograft has more opacity to it. The osteogen is more radiolucent. 1 week post-op, I'm going to see the patient. I don't expect complete closure. I don't care. Okay. I'm going to remove the sutures. 4 months post-op, doctors. It's not magic. You're going to get exactly the same results that I'm showing you today. And I'm able to, from nothing, be able to predictably place our implants. And I wanted to show you what that looks like. Do you remember that big defect there? Nothing magical, doctors. This is something that you will all be able to do. Here I did a core sample for you. And then do my osteotomy. Wider, 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 wider. Placing my implant. Placing my second implant. And you can harvest this bone, this autogenous bone. You can use it to correct any defects. But we place our implants to the crest. And I will suture. And our implants are in good quality bone. And I expect an outstanding prognosis. Again, suturing the site allows for healing. And I will see that patient in a week to remove these sutures. Now I know, a lot of us don't like to see our patients that often, and I don't mind. And I think it's just communicating with your patients. I think the end result is all that really matters. Last time too, Lauren, we talked about the posterior maxilla, where we don't have a lot of bone. And so we have a couple techniques that we can use. I'm going to make my envelope reflection, and I can use an osteotome. I mean, there's different techniques that you use, but we can lift the sinus floor 3 millimeters very predictably and place an implant. That implant has to be at least 70% in viable bone. Or we can lift the Schneiderian membrane up to 6 millimeters, but I would not immediately place an implant. And you can see I'm just simply taking an osteogen plug into that socket site, helping me lift that floor, and I can thread my implant directly into that site to the crest, getting good stability, good torque. And we'll suture over and allow that to heal. So there's not a mystery to what we're able to provide our patients. It's really just training yourself. You can see we're 70% in bone, and we lifted that floor about 3 millimeters. The other more involved is in this situation, if you look at the sagittal view in the lower right hand of your screen, you can see we have almost no bone to work with. We're going to reflect, and we're simply going to make a window. Almost best analogy would be like a dishwasher door. And this lateral bone wall will become my new floor. And with technique, I'm using a piezo. A piezo only cuts hard tissue, not soft tissue. And once I lift that dishwasher door up, I will take my osteogen material, and I can fill that sinus with a true graft. It doesn't go all over the place. And then I'm filling the wall with my allograft material. This is an osteogen sheet. And then I put a membrane on top of it, passively placed. And we will simply suture over that site. Tell the patient not to blow their nose heavily if they are a little inflamed on that nostril, to get some nasal spray. And 4 months post-op, you can see the amount of bone. Remember how little bone we had in the beginning? We now have significant bone where I can predictably place a couple implants, allow them to integrate, get a great tissue response. And here we splinted, because it is in the posterior maxilla, we're able to splint those together and grow bone quite effectively. I know I ran through that quickly, Lauren, but the last time we did this program, we had some very specific questions about some of the extra cases that we put in here. So I'm finished with mine. We'll let Kurt do his thing, and I'm sure we have some questions.
Yeah, I think one of my questions is, can you hear me okay? Would be my first question.
I hear you fine. Can you hear me now?
Yeah, so yeah, it's funny that you and I were joking about never had internet go out in the middle of a webinar, and of course my internet went out in the middle of the webinar. So I did have to jury rig this a little bit. So I'm on my cell now, but I can still do what I need to do. We have some wildfires and some pretty high winds here in LA. So as I mentioned at the beginning, a couple of housekeeping things for those of you who may have popped on a little bit late. We did record the webinar. That recording typically will go out within a couple of days. GoldenDent, who is our sponsor, is going to handle the CE forms. They can sometimes get those out as early as Friday. Oftentimes it takes a little bit longer than that. As long as you were on the webinar, we track when you logged in and when you logged out. So as long as you're here and here for most of it, you'll get the CE. That's done automatically. There's nothing you need to do as far as taking a quiz or registration and like that. We don't do these webinars without GoldenDent coming in and really helping out to provide the speakers and the content for us. So I've been working with Kurt Lawler for probably 10 years plus. I'm going to switch it over to his screen now, and he's going to talk about some special offers that he's going to make, and then we do have a bunch of questions, and we'll open up for the Q&A afterwards. So Kurt, it's up to you.
Lauren, thanks. I appreciate it. This is Kurt Lawler with GoldenDent. Happy New Year, everybody. We're also based here in Detroit, Michigan, like Dr. Kosinski. I'm going to speak quickly here and get through just a couple slides before we go back to the Q&A session here with Dr. Kosinski. So I wanted to mention we have another webinar coming up here pretty soon with Dr. Matt Burton, and also moderated by Dr. Levine again, February 11th. So when we send the follow-up emails for this webinar, take a look for the registration link and sign up while you're thinking about it. It'll be another good webinar, February 11th, 8 o'clock. So for joining the webinar this evening, we are offering a 15% discount code. The code is WEB15, so it says WEB15. The website is golden-dent.com, or you can obviously give us a call in the office at our phone number there on the screen, or we're available on chat. We do these for a quick 24-hour deal, so it expires tomorrow, January 8th. So for anybody that knows GoldenDent, we started with extractions and grafting. Physics forceps was our first product, and then we've expanded to add quite a few more categories since then. But extractions is what we started with, and then grafting that obviously goes along with extractions. So this is Dr. Kosinski's favorite. This was our first product. It's the physics forceps. I know he already explained these instruments, but this is our most popular set, which is our standard series set of instruments. There's one lower and then 3 upper instruments. So we obviously have those available if anybody's interested. You give us a call or take a look online. We have hundreds of videos showing their use over the years. In addition to the physics forceps, we have luxators. We've got your conventional 150, 151 ash type forceps. So whatever your preference is, there's lots of ways to remove a tooth. The main goal this evening was to show some simple grafting techniques. I know we showed some more advanced cases too, but the osteogen plug, which I'll mention here in a moment, is a great way to get involved in grafting if you're not currently offering grafting yet in your practice. This is our simple graft kit. So once you extract the tooth, you obviously have to have the right instruments. It's nice to keep this kit in one place. It's inexpensive. It's going to have your curette, bone file, Orban knife, which was shown, and your instruments that you need to really keep everything in one kit for grafting. So Dr. Kosinski helped us develop this, and this is the Dr. Kosinski graft kit. So it's important to have a serrated curette, as shown this evening. It's important to curette the socket site prior to placing the graft. And this serrated curette here with the little blades in the end does a good job of doing that. Now, if you're unable to, I guess, manually curette the socket site, we also have these tissue and degranulation burrs, which are really excellent for grafting, which also come with bone shaping burrs, some cutting burrs, and really everything you need for your practice for grafting. This is a nice little burr kit I just wanted to mention if you're not able to do the manual curette. So one of the main things we wanted to mention on the webinar tonight was the osteogen plugs. These have been around for a while now. One thing I wanted to mention is there's been a lot of other plugs that have circulated on the market. We have a lot of different documentation on our website. The osteogen plug really is the best plug graft out there. We've shown through different analysis and studies, and you can see this on our site, a lot of the other plugs that have really came out and tried to act like the osteogen plug, they're just not the same. I mean, they have different pore handling. They can turn to snot or ooze out of the socket site prior to healing. And you can go through these, and we always find that anybody that tries a different plug always seems to come back to the osteogen plug. We really do believe it's the best plug on the market. And you can see some of these kind of comparisons we have from different ones that have shown up on the market over the years to act like the osteogen plug, but they really just aren't as good. Make sure I didn't miss what's said. So this is our bone graft. Everybody has a graft. This is one that we find to be, we've sourced it from a reputable bank or tissue bank. We have the particulate and then also the putty form. They're great pricing, different sizes available. We just encourage you to take a look, give us a try if you're using a different brand currently. These are the membranes. I'm not going to mention these. They're all long-lasting, resorbable membranes. This is the PGA suture that Dr. Kosinski mentioned. He likes the 3.0 and the 4.0. Take a look. If you're using a PGA suture, take a look at the ones we have. The pricing is very, very fair. Lastly, I'll just mention we do live patient extraction and grafting courses. We've done these for a long time. These are the upcoming dates. Looks like we get started again for the year in April. And then we pretty much have a class just about every month on extractions, grafting, and then we have one date scheduled so far for our endo program. So those are on amplifydental.com if you want to take a look. Lastly, I just wanted to mention, if you haven't taken a look at our site lately, we have our new catalog out. We brought back our single-use purple matrix rings. Those are quite interesting. If you're concerned about losing a ring, or you need to modify a ring for a specific case, or you need a single-use ring for certain needs, we brought back the purple Wagotrix ring, which is a disposable ring. We also have our night-tie rings, which are new. People asked us for these. We've got the V-shaped green and yellow night-tie rings. We recently picked up the Logi blocks, which is an excellent bite block. And then we also have now we're the dealer for the US for the Rondium Quick Connect system. That's the product we covered on the last webinar. If you're using a Tuffle-Meyer system, this is a really great system where you have a retainerless carrier for the band where you can disconnect it and you don't have a bunch of pieces dangling out of the mouth during the procedure. A really good system at affordable price. Lastly, I know Dr. Kosinski mentioned the Woodpecker surgical motor. I don't have that on here, but we do have all the Woodpecker products, including their new curing light, the O-Star Pro, which is excellent. So I just wanted to mention these 4 or 5 new products that might be new since the last time you visited our site or we did a webinar. And with that, I will turn it back over to Lauren to go over any questions for Dr. Kosinski. Give us a call in the office. Again, if you want to save 15%, it's Web 15. And you can go to golden-dent.com, and I will turn it back to Lauren. Thank you, everybody.
Thanks, Kurt. Tim, we got a few questions here. Are you ready to roll?
Sounds good.
Okay. Do you prefer the membrane instead of PRF?
PRF is just time consuming, Lauren. Patients come in. We see a lot of patients. We do a lot of surgery every day. If it's a bigger case, or if I have time, I don't mind. But it's time. It's 15 minutes to spin the fibrin clot. So I don't use PRF all the time. I don't use it routinely. I don't feel you need it. The results are going to be the same. It's just faster.
Okay. Do you ever do and I think I know the answer to this, like a delayed socket graft where you go ahead and clean out the infection and put the patient on antibiotics and then bring them back in, a month, a couple months, whatever, to then do the bone graft? Are there circumstances where you would want to do that?
Boy, I honestly, I probably never do that. As long as you can curette the site, eliminate the purple blood, I'll use my NV Pro laser, my diode laser, to sterilize the site, and I will graft it. The point I was trying to make is, if you have an active infection, I will never place an implant immediately, but I will graft the site and go back and place the implant 3 or 4 months down the road.
Okay, that was going to be the next question, actually. How long do you recommend waiting to place the implant in a site that had the plug?
Yeah, and you can look at it objectively, radiographically. You can actually see a changeover. And remember, it's going to heal from the apex towards the crest. So the apical half may look more radio opaque than the coronal half, but my initial stability is in the apical 2 millimeters.
Okay, there are a couple of questions about that. What about in a large extraction socket? Can you use cortical Kinsel's bone with an osteogenic plug over the allograft?
Yep, that's what I showed. I showed that a couple times. Absolutely, I will layer it. What I like about the osteogen, particulate kind of moves all over the place, and so in my sinus elevations, I don't want the particulate to be all into the sinus where they're going to be blowing out my expensive material. The osteogen material has some substance to it. It allows me to push the Schneiderian membrane. I can even use my thumb to kind of push it and to stretch that Schneiderian membrane without worrying about damaging it. But absolutely, I layer all the time, yes.
Okay. Can you remind me, what was the name of that crown remover, and are you only using it for crown replacement, or are there other indications for it?
No. The crown, the remover, it's Kurt can help me.
WAM key. Yeah,
The
the
WAM,
WAM
yeah,
key. Yeah,
WAMKY. Yeah, from
we've had that for we've had that product for a very long time. I didn't know you were going to mention it this evening. Otherwise, I would have showed it here. But yeah, it's called the WAM key system, so it's something we have available.
again, efficiency and
It's
time is very
WAMP, right?
Yeah.
Okay.
Yep.
Okay. Okay. I guess some of this stuff you've already went over, but I want to just make sure because I made some people myself questions. How does PGA compare to PTFE for sutures?
It's resorbable.
Right.
Yeah, the Gore materials
Exactly.
not resorbable. Yeah.
Okay. What is the physiological stimulus that causes the release of the periodontal ligament dissolving enzymes, and how long does it take for this dissolution to occur?
It's again, it's a physiologic reaction. You get the tension is causing the release of hyaluronidase to the site, and that is breaking down the periodontal ligament. Again, it really is like a minute procedure, a couple minutes. It's a very, very efficient way of removing teeth. It doesn't work on ankylosed teeth, obviously. And if you have divergent roots, I will section them and take them out individually. But it is an instrument that I literally use every time I do an extraction. That's my go-to. It's rare that I use anything else.
Okay. Obviously, there's different sizes of the oxygen plugs. What factors determine what size is the best to use?
The size of the socket, and Kirk could probably relate to. I think the cost is the same for at least there's a thin, a large, an extra large. There's sheets, there's blocks, and they could probably tell you the difference in cost, but it depends on the socket size.
Okay. Do you typically put your patients, implant patients, on some type of mouthwash? And if so, what kind after implant placement?
No, afterwards, no. Beforehand, we'll have them rinse with chlorhexidine or perioscience to get the bacterial count down. Post-operatively, my rule is, Lauren, that's a good question, is I don't use a lot of antibiotic anymore. Amoxicillin, 500 milligrams 3 times a day for 3 days. If I can start them the day before, all the better, but many of our patients come in, in emergency situations, and we just start them there. Ibuprofen, 600 milligrams, PRN pain. 800 is no more efficacious than 600, so there's no reason to give them any more. It is rare that I give a narcotic, and we do full arch cases. It's so rare that I would give a narcotic. As long as you're not incising into mucosal tissue, you're not going to get a lot of, we just don't get a lot of discomfort. Everybody's a little bit different. Obviously you have patients that have a low tolerance, but I've probably written 10 narco scripts in the last 3-4 years. I just don't give a lot of narcotics. Warm salt water rinses is fine, or the perioscience post-operatively, but it just isn't an issue.
Okay. There are a couple questions about pricing, and I would encourage people, you have GoldenDent's number there on the screen. You have the website. They do have a chat. That's the best way to get pricing. Okay, this one's kind of a multi-part question. Oftentimes, roots on radiographs appear to overlap the sinus. Is the combination of the osteogen plug with allograft and then a membrane a reasonable way to deal with sinus closure? And how do you code for that procedure?
Yes, and I don't know how to code. I'm sorry, I don't do insurance, so I have no clue what the coding is at. Kurt may be able to help you with that, but yes, I would use the osteogen first to close that site. It's great, and then an allograft or just osteogen in that entire socket site. Yeah.
Okay. So another question about the coding, which you're not going to be the best person for that. Do you use CBCT exclusively, and do you ever use surgical guides?
Well, CBCT is a tool that just makes us better practitioners, right? Because we can visualize in 3 dimensions. We can virtually evaluate the site. We can evaluate the implant placement, the size, position, and we can even virtually design our final restoration and communicate with the patient. Yes, I do use surgical guides. I've been doing this a long time, Lauren, and again, many of our for single tooth replacements probably don't. For our full arch, all on X procedures, where we're doing bone contouring and reduction, then yes, we'll do a bone reduction guide and then a implant surgical guide. Yes.
Okay. I'm not sure if I understand the question. Can isogen be used for root coverage? I assume they're not talking soft tissue coverage, but are there other situations where that would be the case?
Root coverage. I'm not sure I understand what that is.
Yeah. Ruth, if you want to explain that or give me a follow-up, I'll be happy to ask that question. Is there any type of collagen?
If some of the root was exposed, can we grow bone on the facial aspect? I would say no.
Okay, yeah, that's what I thought. Okay. Is there any type of collagen membrane that does not require primary closure?
All our membranes today are. I don't use any non-resorbable membranes anymore. Non-resorbable membranes you need primary closure on. I don't use non-resorbable membranes because our resorbable membranes are so well made today, and they last 3 to 4 months or 5 to 6 months. I only need it in place for 6 weeks, and epithelium is going to close a 0.5 millimeter to 1 millimeter a day. That's physiologic. So depending on how big the defect is, epithelium is going to grow over the top in a week, 2 weeks, 2.5 weeks, 3 weeks. It will eventually cover over that socket site.
Yeah.
And once it covers over, physiologically, bone is going to grow from the apex towards the crest.
Okay. I'm not 100% sure on the question. Do you use a smart dentin grinder if the tooth is not root canal treated?
Yeah, I have used the smart grinder, and it worked very, very, very well. A very, very, very impressive piece of equipment. Absolutely. Yeah.
Okay. The Osteogen plug, is that a xenograft or what is it specifically?
No, it's synthetic. It's calcium apatite in a bovine Achilles tendon matrix. It's been used about 30 years. I've been probably using it for 15 years. You're talking about a $50 graft. Don't quote me on that. Versus a cc of allograft is at least $110, $120. A membrane is another $110. So I have $50 of material versus $220 of material. What can you charge the patient for that? And again,
Right.
as I said in the very beginning, setting the foundation is as important as putting the implant in.
Okay, someone's asking about what's the best trick to create the tunnel before placing the membrane because it tends to bind up on them apically. Are there any specific tricks you have for that?
Make a reflection. Make that envelope reflection. Don't make vertical incisions. You can reflect a tissue all the way to the base of the eye or the base of the lower jaw without hurting the tissue. As long as you're not making vertical incisions, you have to see the entire defect.
I'm well aware of that.
Yes.
How are you able to obtain such a dry field after the extraction?
We do a lot of photography, so we're cleaning the site.
Right.
Yeah.
Okay.
Yeah.
What about if someone's getting a lot of dry sockets? Would PRF help with those bad surgical extractions? If someone's always even doing a great graft, do they still end up with dry socket a lot?
Yeah, I guess I don't see. You need a bleeding site to graft. Okay, a dry socket meaning there's no clot in there. So I don't see dry sockets. I don't see dry sockets. I think that's more technique than anything else.
Yeah. Okay. Do you see an increase in radial opacity over time after an implant was placed in an osteogenic grafted site?
The results will be the same whether you use a synthetic material or an allograft material. The results are the same. It's just the materials that we're using. In my experience, the time frame is nearly identical. Again, if I do use PRP or PRF, it will be a little bit faster integration. I'm never in a rush anymore. I've been doing this a long time. Everybody seems to be in a hurry to get things done, but the result, the bone, what we're putting in there is, we're not pouring concrete in. It's biologic. Bone will turn over time, regardless of the material that you use.
Okay. Because some of these questions are really pretty good here. So, okay, for a 5-walled socket, if you are using particulate graft instead of an oxygen plug, do you still use a membrane if you use allograft and no membrane if you use bovine?
Okay, I don't use bovine at all in my implants. Bovine is very, very, very cortical, and I find that it holds a site very, very well, but it doesn't bleed very well for an implant. So I'll be very honest, I don't use bovine at all. The allograft material, yes, you still want to protect it from invagination of epithelium, but let's say you're doing an extraction and you're doing like a flapless procedure and you're just going to drill into the socket, you feel comfortable with it. I would put something over the top of it, even if it's a collagen plug that lasts, 20 days. Again, epithelium is going to grow a 0.5 millimeter a day. I just need to protect that site. Smokers, okay, how do you protect that implant from the tar nicotine heat generated from vaping and or smoking? In today's society, just put something over that. You can make a little manhole cover and put it right over the top and suture over the top of it. But yeah, I would protect it. Yes.
Okay. If you do bone graft with allograft and cover it with collagen membrane, do you always bring the patient back 7 to 10 days later to remove the sutures and then the epithelium will close? How long after?
That's a great, you know what? Yes, I do. I want to see my patients unless they're leaving for vacation or I can't. And I'll tell you why. You communicating with our patients is very critical, as you know, and it's kind of a lost art. You try to tell them everything that could possibly happen, and if you don't, what will happen is you will put sutures, and they will call your office in 3 to 4 days and say, I was doing really well, but something's wrong because it's really irritating me. And it's because the epithelium wants to heal, and the sutures are preventing it from healing completely. If you tell them ahead of time, and I see them in a week, I remove those sutures, it feels better immediately after removing those sutures. So I like to see my surgical patients as long as they allow me to. I like to bring them back and see them. My team will take the sutures out. I will walk in the room and congratulate them on their healing, or tell them that they're 60% healed, 80% healed, 90% healed, whatever. They want to hear that. I make them a part of the process.
Okay. Does Dr. Kosinski offer classes in soft tissue closure after implant placement or soft tissue augmentation after implant placement? I think we've done that in the past, and that'd be a great topic for another webinar.
Okay. Yeah, we have. You have a library? You can maybe refer them to the library.
Yeah, I can probably. I've recorded every single webinar that I've done in the last 10 years, so we have them somewhere. So John, let me see if I can find those for you.
Yeah,
I know we've done that.
I know we have, Lauren.
Okay. We're done with the questions. Anything you'd like to say before we wrap it up for the evening?
Well, I appreciate everybody listening, and nobody's left. That's really nice, and thank you, everybody. I wish everybody a very, very healthy and profitable new year. I think it's going to be a great year. Keep learning. The more knowledge we have, the better the end result. Lauren, I appreciate you and Kurt and the team at GoldenDent for your kindness and your nice words, and God bless. And I hope you have a wonderful evening and a wonderful rest of January. Stay warm.
Thank you, Tim. Well, it's always a pleasure to do a webinar with you. As I mentioned at the beginning of the webinar, your webinars always, always, always have the highest turnout, highest percentage turnout, and the highest gross numbers. So we always have great content, and we thank you for sharing your expertise with us. As I mentioned before, we don't do this without GoldenDent, and you see the special that they have, the Web 15 code, that's on everything site-wide. As Kurt mentioned, there's a lot of stuff that they offer that was not, specifically mentioned during the webinar that we have talked about in previous webinars, and I would definitely encourage you to look into them. We have a lot of our clients who are GoldenDent customers. They rave about the customer service and the products, and I would highly recommend that you take advantage of those special savings as well. You see the phone number that's up there, you see the website, you just call them up or chat with them and tell them what you want to get, and they'll follow up. Final reminder, for those of you who came on a little bit late, the webinar was recorded. That recording typically will go out within a day or two. I'm going to shoot over a copy of the recording to Kurt as soon as this is done, which takes about 15 minutes or so. The CE credits, again, there's nothing you need to do. Once you log out, we will have a report that's sent to GoldenDent that says when you logged in, when you logged out, and as long as you meet the minimum, I think it's 35, 40 minutes, whatever it happens to be, as long as you're here for the bulk of it, obviously, you will be sent to CE. They oftentimes will get those out by Friday. Sometimes it takes a little bit longer. If you don't have it by, say, this time next week, feel free to reach out to me, and I will follow up with them. As Kurt had mentioned, we do these webinars on a regular basis. The next one is February 11th, which will be a great topic as well. All of you who are here this evening will be sent an invitation for that upcoming webinar. Thank you all for joining. Please stay safe and healthy. Happy New Year to all of you, and we look forward to seeing everyone on our next webinar. Good night, everyone.
Have a great one.